oxalate nephropathy. In my previous session, we have dealt about primary hyperoxaluria and its various types, diagnosis, and management. So we will deal with what the other conditions which involves oxalate and kidneys today. So to start with, we'll deal with a case, a 28-year-old gentleman, a lift technician from Tiruvalla. He presented with 12 to 12 episodes of vomiting, abdominal pain, and abdominal distension since 3 days. He had no symptoms suggestive of acid peptic disease, diarrhea, fever, dysuria, hematuria, no abdominal surgery, recent infections. He had ingested about 2 to 2.5 liters of Ilmenpuli Aurora bilimbi fruit juice for 3 days. Aurora bilimbi is a scientific name. He has heard in social media posts and seen that the oxalate, this Ilmenpuli, will reduce the hypertension. So he gives a past history of hypertension, and he's on amlodipine for 1 year, and he had some alternative medicines without scientific evidence as antihypertensive since last 2 years. He had no other comorbidities and hospital admissions. He had a documented creatinine of 1.1 2 months prior to admission, and systemic examination showed a hepatomegaly, and other systems were unremarkable. To summarize, 28-year-old gentleman, hypertensive since 3 years on irregular self-medications with no other known comorbidities and no addictions, had history of consumption of about 2 to 2.5 liters of Aurora bilimbi fruit juice for 3 days for apparently lowering high blood pressure. He is obese class 2 and had hepatomegaly on examination. Investigations revealed a urine albumin 2 plus, RBC was nil. He had slightly raised total counts and slightly raised lipase levels, and his serum creatinine was 8.85 at the time of admission, and with a 24-hour urine protein of 405 milligram per deciliter. And this was a trend in the renal functions over time, and this was after dialysis. So the complement levels, the autoimmune workup, ANCA's ANA profile were negative, and urine was negative for eosinophils. The ECG showed a normal sinus rhythm. X-ray abdomen showed no features of intestinal obstruction. His chest X-ray was normal, and ultrasound revealed no features of obstructive uropathy. Echo was showing a left ventricular hypertrophy consistent with LVH. So the differential diagnosis considered was acute kidney injury due to acute tubular necrosis, acute interstitial nephritis due to Ilmenpuli or oxalate, and rapidly progressive glomerulonephritis, any other underlying glomerular disease because he had proteinuria. So he was initiated on emergency hemodialysis. He was pulsed, given oral steroids later on, and restarted on antihypertensives. He had good urine output, and he had undergone 4 sessions of HD, and hemodialysis was withheld and watched for reversibility. And meanwhile, the ophthalmology consultation showed a grade 2 hypertensive retinopathy, and he had a stable cardiac status. A renal biopsy was done, which showed interstitial infiltration with lymphocytes. And here you can see a fragmented oxalate, and the tubules revealed features of acute tubular necrosis, and there were some involvement of ETN with tubuloinitial nephritis picture in the biopsy. The glomerulus and vessels showed no significant pathology. IF was negative. He was discharged with a creatinine of 2.26 milligram per deciliter. On follow-up, his oral steroids were tapered and stopped, and his serum creatinine was 1.7 after 4 days, and after 2 weeks, it was 1 milligram per deciliter. So what is Aurora bilimbi? It belongs to the kingdom Plantae, and this is the leaf, and this is the fruit, and this is the flower of this Idimbenpuli, which is very common in South India. So in Kerala and Batkal, it is used for making pickles to make fish curry, especially with sardines. Karnataka, Maharashtra, and Goa, the fruit is commonly eaten raw with salt and spice. In Philippines, the leaves serve as paste on itches, swelling, mumps on skin eruptions. The leaf infusion is even used as an afterbirth tonic. Flower infusion is used for thrush, cold, and Malaysians use fermented or fresh bilimbi leaves to treat venereal disease. In Thiruvananthapuram, the fruit of the bilimbi was used in folk medicine to control obesity. So you cannot blame this patient of ours in taking this Irimbenpuli, which was high in oxalate, but which he didn't know. He had consumed more than 400 ml per day. In French Guiana, syrup made from the fruit is used to treat inflammatory conditions. Also, the fruit contains high levels of oxalate and AKI due to tubular necrosis is common. So these are the herbal causes of AKI in tropical countries. The list is very far, very vast. And Aurea blimbi irmenpulli is more common in South India. We have more case reports here. And oxalic acid is the active molecule which causes tubulointerstitial nephritis, intratubular obstruction, kidney syndromes induced by other herbal medicines. The list is again very vast. Most of the Chinese herbs are known to cause kidney involvement. Coming to the topic proper, oxalate nephropathy. Oxalate nephropathy, as the term, means an acute or chronic decrease in kidney function associated with the deposition of calcium oxalate crystals in kidney tubules, typically acute tubular injury, and an associated acute chronic interstitial nephritis or fibrosis. And oxalate as such, if you take nephrocalcinosis and oxalate nephropathy, both are different. They are not the same. The term oxalate nephropathy is used in preference to nephrocalcinosis because nephrocalcinosis also includes calcium phosphate deposition. Nephrocalcinosis is also often used as a term to describe calcification of the renal parenchyma as seen on radiological imaging, while oxalate nephropathy implies a pathological diagnosis. Till now, the prevalence of oxalate nephropathy is based on case reports, but two recent reviews have addressed this. In a Belgian series from 2010 to 18, they have made that on kidney biopsies that oxalate nephropathy made only about 1% of the cases, and another study which included concomitant diagnosis found that the prevalence of oxalate deposition was as high as 4% of biopsies. So oxalate deposition in this study was considered the primary or contributing cause of kidney disease progression in 88% of the cases with an estimated prevalence of 3.6%. Then primary hyperoxaluria, we have dealt in the previous discussion, autosomal recessive disorder, calcium oxalate nephrolithiasis, and multisystem deposits. While the median age of onset is 5.5 years, it can still present in adulthood with kidney stones or kidney failure and should be considered in cases of hyperoxaluria and oxalate nephropathy without another obvious cause. So there is some overlap between primary hyperoxaluria and enteric hyperoxaluria. So there is a definitive distinction has to be made between pH and enteric hyperoxaluria or EH, which cannot be generally made based on urinary oxalate excretion alone. Systemic oxalosis due to very high plasma oxalate levels is common in primary hyperoxaluria as renal failure progresses, but this is seen only very rarely in other forms of hyperoxaluria. And in patients with renal failure, very high plasma oxalate levels might be useful in distinguishing pH from secondary hyperoxaluria. So what are the causes of secondary hyperoxaluria? Increased dietary oxalate or oxalate precursor, such as ethylene glycol or vitamin C intake, fat malabsorption from various causes, chronic pancreatitis, pancreatitis, Roux-en-Y gastric bypass surgery, short bowel syndrome, Crohn's disease, use of orlistat, decreased intestinal oxalate degradation, secondary to reduced intestinal colonization with Oxalobacter formigenes, low GFR, hypovolemia, use of RAS inhibitors and diuretics, and older age all have been anecdotally associated with development of oxalate nephropathy in patients with hyperoxaluria. The PH1 diagnosis, which accounts for about 80% of the cases, is also the most severe subtype, and the definitive diagnosis requires genetic testing such as mutation in AGXT. And it is notable that the urinary oxalate excretion tends to be higher in pH than in enteric hyperoxaluria. Enteric hyperoxaluria is defined by hyperoxaluria occurring in the setting of fat malabsorption or steatorrhea. Normally, calcium binds the oxalate in the bowel to form calcium oxalate, which is insoluble and that is excreted in the feces. In a state of fat malabsorption, calcium is bound by free fatty acids and becomes unavailable for oxalate binding. This is then increased soluble oxalate which is available to the absorption by the bowel. Free fatty acids and bile salts may also directly increase the colonic permeability to oxalate. So an intact colon appears likely to be important for oxalate absorption. And hyperoxaluria in enteric hyperoxaluria has generally not been observed in patients where the colon is not utilized, such as in patients with ileostomies after colectomy. Solute link carrier 26 anion exchangers, which are a family of transporters that mediate transcellular oxalate transport, are differentially expressed along the gut, though it is felt that most oxalate absorption likely occurs paracellularly. The risk of calcium oxalate precipitation is worsened by volume depletion, which can lead to metabolic acidosis and hypocitraturia. These are the simplified hepatic pathways of glyoxylate mechanism, which we have dealt with primary hyperoxaluria in my previous discussion. Surgical intervention. Both nephrolithiasis and oxalate nephropathy were frequent complications of one of the first surgical treatments for obesity, jejunal bypass. And this procedure involved bypassing much of the small bowel, causing significant malabsorption. The procedure was largely abandoned in 1979 due to its high morbidity. And more recently, Roux-en-Y gastric bypass, which replaced jejunal bypass as the procedure of choice for malabsorptive bariatric surgery, has been recognized as a cause of oxalate nephropathy. So other malabsorptive states include chronic pancreatitis after bowel resections for IBD. Orlistat, a weight loss agent that causes fat malabsorption, has similarly been recognized to cause hyperoxaluria and oxalate nephropathy. While IBD is often listed as a cause of oxalate nephropathy, reports of oxalate nephropathy in IBD have virtually all been in patients who have had previous bowel resections and with presumed malabsorption. Similarly, while malabsorptive bariatric surgery such as jejunal bypass and Roux-en-Y surgery is strongly associated with oxalate nephropathy, this has not been seen with restrictive weight loss surgeries such as sleeve gastrectomy, where the small bowel is not bypassed. Now, what are the ingestions which are causing oxalate uh, nephropathy? Ingestions include direct consumption of high oxalate foods and also ingestion of oxalate precursors. A classic and dramatic cause of ingestion-related oxalate nephropathy is ethylene glycol, which is an active ingredient in antifreeze, but is also present in number of solvents, paints, and other industrial and commercial products. Ingested ethylene glycol is metabolized in the liver to oxalic acid and causes acute oxalate nephropathy with acute tubular injury and oxalate crystal deposition in tubules. And there are frequently numerous urine calcium oxalate crystals which is present in the urine that can be a sign of the diagnosis. So calcium oxalate and monohydrate and dihydrate crystals in spun urine look like this. There have also been multiple case reports of oxalate nephropathy associated with high dietary oxalate intake from a number of sources as well as ascorbic acid. And these reports have generally involved excessive intake of high oxalate foods or mega doses of vitamin C. So some cases have been reported involving moderate amounts, especially with chronic intake. And there have been reports of oxalate nephropathy from juicing of vegetables such as spinach smoothies in one report and an assortment of high oxalate vegetables together with ascorbic acid in another. And it has been speculated that juiced oxalate foods may be more effectively absorbed in the intestine via paracellular pathway, via solvent drag, and because of dilution of calcium by water. Star fruit, carambola, and vitamin C supplements. The most frequent case reports nowadays involve the star fruit and vitamin C supplements, while the other injections are reported nowadays less commonly. Vitamin C is likely a more bioavailable source of oxalate than food. This is because oxalate in food is complex with calcium as well as a degree magnesium, limiting absorption. Furthermore, vitamin C is taken by a large segment of the population, sometimes at very high doses. It has recently also used as an intravenous dose as treatment for sepsis, including in patients with COVID-19 infection. It should be also noted that there is a significant amount of vitamin C in common beverages such as apple juice or orange juice, approximately about 800 milligram per liter. So this is the metabolism of ascorbic acid to dehydroascorbic acid to 3-ketogluconic acid to oxalate. So these are the reported ingestions causing oxalate nephropathy. In my first case of Inumbinpuli, the 150 to 400 ml juice per day is the quantity of a typical reported ingestion which is causing a biopsy-confirmed oxalate nephropathy. So this patient has an intake of about 800 to 1 liter per day of Idimbenpuli juice. And this is star fruit. About 200 to 3 liters of pure juice have reported biopsy confirmed oxalate nephropathy. Then vitamin C, 2 to 6.5 gram per day. Then we have others like peanuts, cashew nuts, almonds. These are all high oxalate containing foods. Rhubarb, beets, black iced tea, juicing, nafronil oxalate about 7 gram per day for toothache and otalgia was given. Star fruit, carambola, and vitamin C. Again, it may be a frequent culprit, star fruit, but even though it is estimated to contain less oxalate than spinach or rhubarb by weight, possibly because it can be consumed as a concentrated juice, the risk of oxalate nephropathy is more because when you take as a fruit juice, you consume more. It has been suggested that star fruit may contain a neurotoxin as well, and there have been case reports of acute neurological symptoms from star fruit ingestion. So it might come to medical attention more frequently because of these associated symptoms. Antibiotic use, especially antibiotics that deplete intestinal oxalobacter formigenes, which metabolizes oxalate, could lead to hyperoxaluria. Studies have shown that depletion of gut oxalobacter was associated with increased urinary oxalate, especially in kidney stone forming patients. And a recent study by Tyson et al. Showed that antibiotic exposure was associated with the risk of kidney stones more than 3 months after exposure. So this certainty does not prove causation, but further research is needed on this possible association. Diabetes, approximately about 35% of the patients has documented diabetic glomerulopathy on biopsy. This could be because the older population, the mean age is 60 years, and diabetes is more common with aging. Diabetes has also been associated with increased oxalate excretion, perhaps by an increase in the oxalate precursors such as glyoxylate and glyoxal that has been observed in diabetes. Diabetes is also associated with gastroparesis and enteropathy, which would make these patients more prone to volume depletion and an increase in urine supersaturation of calcium oxalate. And not all patients with hyperoxaluria develop oxalate nephropathy, and a concomitant insult such as a volume depletion may be a precipitating factor causing oxalate nephropathy. The main intervention used in most patients in case series and case reports is hydration, either IV or oral, which would serve to lower the concentration of urinary oxalate. Oral citrate has been used to inhibit crystallization in both primary and secondary hyperoxaluria, though the outcome data are limited and the treatment of pH depends on the mutation. Pyridoxine may be useful in type 1 and liver transplantation. Lumasiran for PH1 approved in November 2020, RNA interference agent that degrades the messenger RNA for the hepatic enzyme glycolate oxidase, and it prevents the conversion of glycolate to glyoxylate. And this agent decreases the amount of glyoxylate available to which is converted to available to be converted to oxalate. So this is a nutshell the treatment review pH, which we have already discussed. Secondary hyperoxaluria, high fluid intake. Mechanism is by lowering the urinary calcium oxalate supersaturation. Enteric hyperoxaluria, increased calcium and low fat intake, which will help to use the calcium to bind oxalate in the gut and lower the oxalate intake. You need to have sometimes 7-phosphate binders, cholestyramine, reversal of bariatric surgery, reloxylates, which is a recombinant oxalate decarboxylate. There is only very limited data. One clinical trial is ongoing. Then there are cytokine or inflammasome inhibition, more data we require. Then ingestions, obviously you identify and remove the offending agent from the gut, ethanol and formimazole. Coming to the second case study of a 59-year-old woman with CKD who presented with creatinine of 4.1 milligram per deciliter, and she had undergone a Roux-en-Y gastric bypass performed 10 years earlier. A diagnosis of oxalate nephropathy was made on diagnosis, and oxalate nephropathy is a known complication of gastric bypass. Calcium and oxalate in the intestine form calcium oxalate complexes that are then excreted. In the setting of fat malabsorption or enteric hyperoxaluria, enteric free fatty acids are elevated and bind calcium with the intestinal lumen. inhibiting the formation of calcium oxalate. The increased amounts of soluble free oxalate is absorbed by the colonic mucosa, and this is enhanced by free fatty acids and bile salts. The absorbed oxalate is excreted by the kidney and then deposited in the renal parenchyma, forming stones. So this is oxalate nephropathy, H&E staining, demonstrating the oxalate crystals. And this is the three-dimensional view of renal oxalate crystals from the same region. So oxalate nephropathy is a serious condition, and that may be a less uncommon than previously recognized. There is a high risk of progression to renal failure. It is crucial to have high index of suspicion in those with unexplained renal dysfunction, as it is likely that early identification and treatment may afford a better outcome, as renal function at presentation appears to be a strong marker for prognosis. So what are the future directions? This is my last slide. The possible impact of antibiotic use as a cause or contributor to oxalate nephropathy via its effect on the intestinal biome. It requires further study. We all use antibiotics. The role of SLC26 oxalate transporter in oxalate physiology as well as pathophysiology of hyperoxaluria needs further elucidation. These transporters may also potentially be targets in managing hyperoxaluric states. Therapies are being developed for both primary hyperoxaluria and enteric hyperoxaluria, including the use of RNA inhibitors to target affected enzymes in primary hyperoxaluria and recombinant oxalate decarboxylates in enteric hyperoxaluria. The role of inflammation in oxalate nephropathy, including by targeting NLRP3 associated inflammasome as well as inflammatory cytokines, is under investigation. So with this, thank you. Over to Dr. Wheeler, sir.